Good afternoon. First of all, let me apologise to all of you for the slight delay. The problem has been caused with establishing a satisfactory link, I think, with Scotland. But Scotland, you're with us, if I can call you Scotland. That's Dr. O'Brien and Dr. Hacking. You're with us and you can hear me?
Yes, and I'm hoping you can hear us too.
Yes, well, we can, absolutely. Let me check that we have the same position from Northern Ireland.
Yes, I can hear you, thank you.
And
I can also hear you.
Thank you very much, Mrs. Leonard. And here we have Louisa Stewart, Dr. Stewart from England, and Dr. Coffey sitting nearest to Miss Scott, who will be asking the questions. Let me explain that you will be asked questions and your answers will be heard not just by the audience here, which consists in front of you largely of participants and co-participants. To the left, lawyers representing the various interests of different people in the inquiry, and at the back a representative of the press. But beyond this room, to a breakout room in this building, and to those who are watching on YouTube and live stream. And this week it's generally been around three figures, going up perhaps to as many as 300 on occasion. I can't tell you how many are watching today, but it'll vary between those numbers. In a moment, Mary will invite you each to take the oath. Mary.
Please state your full name.
Caroline Louise Coffey.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Louisa Jewel Stewart.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Right. I'm talking to Northern Ireland now. Just so that you know, because otherwise you won't be able to know. So if I can swear in Dr. Meakin first.
Okay.
Do you have a Bible there?
I do, yes.
Great. Please state your full name.
Dr. Sarah Meakin.
And repeat after me, holding the book in your raised hand. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Okay. And now Mrs. Leonard. Please state your full name.
Caroline Ann Leonard.
And repeat after me, holding the book in your raised hand. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
The evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
And now to Scotland. If we start with Dr. O'Brien. Please state your full name.
Grania May O'Brien.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
the whole truth,
and nothing but the truth.
and nothing but the truth.
Please state your full name.
Belinda Hacking.
Take the book in your raised hand and repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Now, just before we start the questioning, may I ask those of you who are remote, that is Scotland and Northern Ireland, if you heard clearly enough or loudly enough the oaths when they were given by the two witnesses who sit here? You're nodding. Good. I just wondered because the volume was a little bit lower, I think, for us in this room, but no doubt that can be adjusted. Miss Scott.
I'm going to start by inviting you all to introduce yourself and give us a short explanation of your background and your current role, so that those that are listening can understand why you've been invited to form part of this panel this afternoon. So can I start, please, with Mrs. Leonard?
Good afternoon.
Yes. Can you tell us what your current role is?
Yes, I am the Director of Cancer and Specialist Services in the Belfast Health and Social Care Trust here in Northern Ireland. And that role, sorry.
No, continue, please, sorry.
I was going to say that role is in providing strategic and operational responsibility for a range of services in the Northern Ireland Cancer Centre, some medical specialties, laboratories and pharmacy. The Northern Ireland Haemophilia Comprehensive Care Centre is within my managerial remit, and as such I'd been nominated by my Chief Executive to provide a coordinating role to the inquiry.
And is it right to understand that the Belfast Health and Social Care Trust are commissioned to provide psychological services by the Health and Social Care Boards, including the specialist service for those infected and affected by infected blood?
Yes, that's correct.
Can I then turn, please, to Dr. Meakin?
I am Head of Psychological Services within the Belfast Health and Social Care Trust, and I'm responsible then for the delivery of psychological services across the various directorates in the Trust, including into Mrs. Leonard's directorate and including then to the affected and infected service.
And so what role do you specifically discharge in relation to this specialist psychological service for the infected and affected?
So I'm responsible for managing it and providing some supervision into it as well.
Thank you. Can I turn then to Scotland and start with Dr. Hacking, please?
Yes, my role is the Director of Psychology Services across NHS Lothian. That includes 4 health and social care partnerships. My responsibilities are for the strategic and operational management and clinical governance of the delivery of psychological interventions and psychological treatment across Lothian. That the services for those who've been to do with the inherited bleeding disorders service, and for people with psychological need associated with that, and other services come under my remit.
Thank you. And Dr. O'Brien?
I am the lead clinical psychologist for the psychological support service for inherited bleeding disorders in Scotland, and I work with people with inherited bleeding disorders, which include those people who have been infected or affected through blood product. I also line manage the other psychology service, the Scottish Infected Blood Psychology Service in Scotland, and currently am the lead for the Haemophilia Psychology Association in the UK.
Thank you. Dr. Coffey, can I turn to you?
I'm a consultant clinical psychologist working in the Wales Infected Blood Support Scheme, which means I manage the psychological aspect of the service, but I also work clinically with people who have been infected or affected by contaminated blood products.
And then Dr. Stewart.
My name is Louisa Jules Stewart. I should probably specify that my title is doctor, but I have a PhD. I am not a clinical expert, and I think that's really important for this audience to be aware. I am Director of Policy for Mental Health and Learning Disabilities and Autism at NHS England. NHS England is an arm's length body of the Department of Health. And at NHS England, I am responsible for overseeing the mental health programme, including negotiating and agreeing with the Department of Health on the the targets and resources that are set for the NHS in England regarding mental health. And we work closely with DHSC, the Department of Health and Social Care, and the English Infected Blood Support Scheme.
One of the issues we're going to be exploring today is the different provisions in the different countries. Can you help us to understand what role NHS England has in commissioning and delivery of specialist psychological services in England?
So in terms of, and I'm going to frame it slightly differently because I think it's not, so actually I'm going to ask a question back. Specialist psychological services in general terms or specifically in relation to infected blood?
It's specifically in relation to infected blood.
So specifically in relation to infected blood, we are providing clinical and operational advice to the Department of Health and Social Care and would find a mechanism for commissioning of any decisions they take and are funded by the Department of Health and Social Care over and above the current provision. It may well be worth adding that the provision that is available in England at present includes improving access to psychological therapies, which is a programme expansion of which sits within NHS England's remit. There are additional services available in terms of funding, but that is not within our remit. That sits within the remit of the English Infected Blood Support Scheme.
So you have NHS England has a role in advising the Department of Health and Social Care about schemes, specialist schemes for infected, those that are infected through blood and blood products.
Yes, that is correct. It is also, if the department commissioned us to do so, we would also ensure that the NHS provided specialist support that they commissioned us to do.
So, but the body that makes the decision about whether or not there should be such a scheme, whether or not it should be funded, is the Department of Health, is it?
That would be the Department of Health and Social Care, based also on our advice and input.
I'm going to then turn back to Northern Ireland to start us off in telling us about what psychological support is available for those that have been infected and affected by blood and blood products, and how they can access it, and broadly how it works. So either of you can answer this question, but is it right to understand that since 2019 there's been a specialist clinical psychology service at the Royal Victoria Hospital in Belfast for those affected by and infected by blood and blood products?
Yes, that's correct. If I may, I'll maybe start and then Sarah can pick up the thread from me. Back in 2018, upon receipt of original correspondence from the inquiry solicitor, we formed a working group in Belfast to determine how we would respond to the inquiry. As part of that working group, we determined very early on that there would be a need for specialist psychological support to the infected and affected, being as they would be remembering and reliving some key events that were potentially very harmful to them in previous years gone by. So with that premise, we made a business case to the Department of Health and secured the funding to employ a clinical psychologist who took up position in January 2019. And I'll hand over to Sarah then, who can explain the mechanism by which referrals are made, etc.
So that dedicated service has been there since January 19, and previous to that there were referrals at the end of 2018 which were picked up by our sort of generic psychological services available within the health psychology remit in the Trust. Since the specialist service has been available, we have a direct route then for referral directly to that specialist service, and there is, I suppose that can be done through, there's a phone number that is available, and also a referral form, and direct access. There's no, you don't have to go through anybody else, go directly to the service that is providing the support. But there's I suppose in terms of how people know about the service, we developed a leaflet in February 2019. We engaged with our colleagues in the Haemophilia Society. We sent out information through a number of the other charities and also to the inquiry team. More recently, a letter was sent to everyone on the database, which included the leaflet around the provision of psychological services. And we also have a number of posters up around various ward and outpatient clinics of relevance within the hospital site.
And who is able to access the service? Is there a criteria for acceptance onto the
Anyone
onto the scheme?
who has been infected and affected by the infected blood issues.
So that would include, would it, in terms of the affected community, that would include family members, would it also include carers and so on, friends?
Yeah. Not so sure whether we've had anyone who's, in terms of friendship, and certainly in terms of family members, and we have had open criteria in terms of siblings and parents and anyone within that family circle, and children as well who are now adults, and the potential to see children below the age of 18 if required.
Is there a waiting list for to be provided with services on the scheme?
Haven't had any significant waiting list. We would have a criteria of usually seeing in terms of 12 weeks, but nearly all of the referrals have been seen within 6 weeks, and many before that.
And what kind of psychological support can be offered under the scheme?
Do you mean in terms of therapies delivered?
Yes,
or?
yes.
There's been a range of supports depending on the presentation. So the psychologist is a clinical psychologist with a range of potential options in terms of her therapeutic background and skills. So it has very much depended on the presentation. We've seen people in terms of adjustment and loss and grief, in terms of responses and reactions to the inquiry and memories from the past. We've seen people around mental health presentations such as depression and anxiety and trauma responses. So it's been the very wide range of sort of psychological presentations that you would expect from this type of challenge.
And how are sessions delivered? Do they take place in person, or are they remote, or is there a mixture?
So there's a mixture, and initially, obviously when we started, it would have been pre-COVID, and the sessions would have been delivered mostly face-to-face. And when COVID came, we were able to move very quickly to offering virtual sessions, and more recently we have given people a choice of whether they would like to attend in person or virtual, and have been able to facilitate both.
Is it right to understand that by the end of September 2002, 34 people had used the service?
Yes, I think we have 38 people who have been through it as of today.
38. How long can services be offered to people? Is there a defined amount of sessions?
No, we do not have any cap on the number of sessions that people can have, and nor do we have any cap in terms of returning. So we have had a number of people who at a point in time have sort of been agreed that they don't require any more input at that time, and have subsequently come back as a sort of re-referral in, and we've been happy to accept that. So there is no cap or any issues in terms of returning at a later date.
And just in terms of how the service is funded, is it right to understand that funding is secure for the life of the inquiry, and that funding comes from the Department of Health? Northern
Yes,
Ireland?
it is.
Yeah.
Yes, that's correct. We had secured funding for the duration of the inquiry. Initially, the anticipation was that that would end around March 2021. However, we obviously are still in the middle of the inquiry, and so the service is still being provided with funding from the department. I should also add that I'm now in discussion with our commissioners to develop a business case to see that the service embedded as a core business in the haemophilia centre for all individuals with inherited bleeding disorders, not just those who have been infected and affected, because certainly our wider multidisciplinary team have seen the benefit of the integration of a psychology service to us in providing a holistic service for our patients. So yes, I'm working now with our commissioners to determine a funding model there going forward.
So in terms of those people accessing the service who don't have an inherited bleeding disorder, is the expectation that the service will come to an end when the inquiry comes to an end?
No, our anticipation would be that we would still address the needs of the group infected and affected by the inquiry, but that we would widen the referral criteria to look at all individuals who have inherited bleeding disorders who have not been affected by the inquiry and its terms of reference, so that we can provide a more holistic service to that population going forward.
So you're describing a widening of access to psychological support after the inquiry rather than a narrowing or an ending.
Exactly.
So I think we're very mindful in terms of even the evidence base as to the need for psychological support in the inherited bleeding disorders, and keen to ensure that that is part of the MDT provision moving forward.
And one of the issues I want to come back to a little bit later on this afternoon is to get all of your views on how long these services might be required for the infected and affected community. Can I turn then to Dr. Coffey? I'm going to ask very similar questions of you. So can you tell us a little bit about the scheme and how long you've been involved in it?
I joined the scheme in November 2019, and I think that the other aspects of the scheme were already established, but the kind of psychological part of the scheme was then formed around that time. So with myself and a colleague who's a counsellor, so there's two of us who are employed to manage the psychological and emotional aspect of the service. So I joined in November 2019. How it's set up is that we are based in a cancer centre in Cardiff, and we offer an open-ended service similar to Ireland, so we have no cap on the amount of sessions that people can access, and we are open for referrals for people infected and affected, and that is flexible and wide-reaching. We have had friends access the scheme, of course family, partners, children, seeing 3 generations of one family within one piece of work. We do individual sessions in person, obviously online, phone, couple therapy, definitely family therapy. And I think that what's been important for us is that we can try and reach the needs of what people come with as much as possible. We have even offered home visits where we can, and when it's appropriate. We have a self-referral process so that anyone can make that self-referral and doesn't have to come from a health professional. And that's open to people affected as well as infected. and we are trialling, I guess, some focus groups and workshops with our clients to work out what is needed on a group and a community level. So at the moment, most of the work has been individual and, as I said, family or partner work, but there's definitely scope for us to broaden that, really.
And are you there referring to the wellbeing service? It's been called the wellbeing service.
It's called the Wellbeing Service because there's a psychologist and a counsellor employed, so we didn't want to call it a psychology service only.
And in terms of the scheme, then, is there a waiting list?
No.
And in terms of the number of people that you've provided support to, the evidence suggests it's 36. Does that sound accurate to you?
I think it's probably a bit higher than that. Now, Katie, maybe kind of, reaching mid-40s, I think. Yeah.
In fact, I've got that was wrong. It says 36 people that are actively being treated at the moment.
Yeah, so I
but
think
in fact it's more like 80 people.
The active number would be probably in the low 40s, but there's more people that have come through the service because obviously some people would only have, say, a short number of sessions, whereas some people are ongoing and have been seen from the beginning and are continuing to be seen. So that number is the active number.
And there's the witness statement of Chris Jones, the CMO. We don't need to put it up. But for the transcript, it was WITN 4065009. Suggests that over 80 people have accessed the service. Does that accord with your recollection?
Yeah.
Do you know, or can you help us at all with how long the service has funding for at present?
My understanding is that, and again, I might need clarification on this, my understanding was the original funding was for 3 years, but we've already reached that point, so it must be ongoing. So I don't know when it's due to end. There hasn't been any conversations that I'm aware of about it ending.
And do you know why the Welsh Government decided to commission specialist support for the infected and affected?
Well, I think from from the conversations I've been part of, it seemed, the most appropriate way really for that to go, because this is a specialist situation. It's not a kind of, I guess, a situation that lends itself, I guess, neatly or nicely into other service provisions. So I think that was probably the rationale, that actually setting up something with people who have specialist knowledge and an interest in this area would be the most suitable option, I think.
Some of the witness statements that have been disclosed mention that the development of a wellness service, which might include buddy schemes, social events, regular virtual meetings facilitated by counsellors and so on. Is that something that you know about, that you can tell us about?
Yeah, it's something that we've been working through. I think it's definitely something that still is in development, and it's something that's really hard to, I suppose, design so that it meets everyone's needs. We have been having focus groups online with clients to try and identify the best way to kind of organise that, because obviously we are an all Wales service. So trying to have something which is going to be held in some community way, which is going to be able to be something that people can attend, is quite hard to know where to locate it. So we've definitely been getting feedback from questionnaires, focus groups, I guess informal feedback that we have from working with clients ourselves or from the rest of the service about how we take that forward. We do now have the beginnings of that buddy scheme in place, where people can be, I guess, joined up, I suppose, with someone else, with their permission and consent, of course, who is also part of the scheme, where we think that would be a helpful match, because that peer support, I think, is really important. And yes, we have certainly tried to provide more of a kind of wellness option, rather than it just being about individual psychological appointments. We do work quite closely together in the Wales service as well. So us and the finance department and the benefits advisors, we do work really closely together, and we do have regular meetings, which I think is a really helpful approach for people that use the service. We've had some really positive feedback, and it does allow us to kind of get internal referrals that I guess would be really hard for us to get otherwise, because I still think there's still some maybe stigma, if that's the right word, with people coming forward and asking for psychological or emotional help, whereas if they're having conversations with someone in the scheme ordinarily about the financial component, and then they're told about the emotional support, sometimes it's easier to access that way.
So is that an advantage that you see in the service sitting within the larger structure of the payment scheme?
I think it is, yeah.
I'm going to turn now to Scotland and again ask similar questions. I'm going to start asking first of all about the psychological support service for inherited bleeding disorders. Can one of you tell us a little about that, when it started and how it operates?
Okay, so I'll start by giving the description of the funding, and then Grania, who operates the service, will be able to give a bit more detail about how it's run. So in 2016, the Scottish Government and National Services Division, that's NHS National Services Division, established a 2-year pilot for psychological support for those with inherited bleeding disorders. That funded the full-time psychologist, and Grania took her post in January 2016. And in September 2015, just a few months before, liaison psychiatrist, for 1 session a week, had previously started work. That was extended to 2018, and then there was an intention that was put into place around extending the service beyond Lothian to other boards across Lothian for those who had been infected and affected in terms of inherited bleeding disorders. Would you like to say anything more? Yeah.
No problem. So from 2018, we started to offer our input to anyone with an inherited bleeding disorder across Scotland. In Scotland, there are 5 haemophilia centres, so that is who we liaised with and who we continue to liaise with. Since then, that pilot was extended and continued to be extended through joint funding from the Scottish Government and NSD, and recently we've had positive indications that funding will continue long-term permanently for this particular service, which is excellent news, as it is a very well-used service, and it has, as been mentioned previously, it's been very much embedded within the MDT for inherited bleeding care, which I think makes a big difference to the people we work with, but also the other healthcare professionals, that they have easy access to psychological support. I'm unsure of what exactly would be helpful to hear about the service. I think the last time that there was numbers submitted was quite a while ago. It was the first submission that Dr. Hacking submitted, and since then we've had an increase. So up to this date, we've had 255 referrals to the service, and of those referrals, 47% have been infected or affected. So just under half of the patient group that I work with are directly impacted by the contaminated blood issues. I suppose just a reflection I had as I was thinking about this preparing is sometimes with the haemophilia and inherited bleeding population, even those families who haven't been directly impacted have been affected because of the community and the association that is often there around haemophilia and HIV or Hep C. And I thought it was worth mentioning that even those that don't necessarily meet the criteria for being affected according to what we would see written down can often still bring that as part of their story, which can feel really helpful to have that as part of the conversation when they come to our clinics.
And what's the criteria for getting help on the scheme is for those with an inherited bleeding disorder and their family members. Does it go any wider than that? Carers, friends?
We've had one situation that was slightly out with that, but made sense in relation to the case. So I think we're very fortunate in our service that we're able to be quite person-centred in our treatment planning, and very similar to what some of the other services have said, we do not ever hold a long waiting list. Generally, when someone is referred, we will see them always within 10 weeks, normally a lot quicker than that, and we do not have a cap on how many appointments that will be offered. We will do whatever is appropriate for that person at that time. Sometimes it may be that it is a small piece of work and that somebody is discharged and that they can re-refer to the service in the future if it is appropriate. Sometimes it may be that there is certain cases that we take on, we do a piece of work and we continue to have a supportive role throughout the inquiry, as it has been quite a challenging experience for some of the core participants to be part of it. So sometimes we act as a support network in a slightly less frequent meeting situation. So we're lucky to have the opportunity to do that in the services that we run.
And what kinds of psychological support or treatments are you able to provide?
So within our service, we have provided one-to-one therapy, and that's from a number of different therapeutic modalities dependent on what somebody is presenting, what the issues are, what is causing the distress or impacting quality of life. As was mentioned previously, that is a wide array of issues that might be anything from anger, stigma, shame, guilt around possibly being a sibling who didn't receive contaminated blood product. It might be working with a parent who perhaps was involved in giving treatment to a child. We work with depression, suicidality, trauma, PTSD, issues that people might have in seeking help from the NHS due to some of the experiences they've had. We might work with somebody to help them to re-engage with treatment, to help themselves physically or psychologically. And I'm sure there's, and obviously bereavement, loss, grief. I'm sure there's loads that I haven't thought about that have been mentioned throughout the inquiry by the core participants. And we work individually. We also might work to try to advocate for people or to liaise among the wider team. So kind of a systemic approach perhaps with the medical team, or sometimes with family members, or whatever the issues may be, that we can be very individualistic in designing our interventions.
And how can somebody access the service? How can they refer themselves, or can they refer themselves, or do they need to be referred?
No, so they can be referred through their healthcare professionals who are linked to the team. We've had a few referrals have come through primary care. We've had many referrals that have been either self-referrals or through the haemophilia charity in Scotland, that they may reach out to the charity, have a discussion, and at that point it may be that our service is recommended. So we are again, we try to get rid of as many barriers as possible to enable people to access the service.
And in terms of how the sessions or how the work is delivered, is it right to understand that you have weekly clinics in Edinburgh and you have clinics in Glasgow? Is that right?
Yes. So that was our plan pre-COVID. Obviously, COVID brought about quite a few changes given that the haemophilia centres are within acute hospitals. So we tend to be very flexible in how we approach things, that we offer telemedicine, which we did do pre-COVID also, but we will offer telephone reviews, near me, online appointments, or face-to-face, and generally it is something that we negotiate with each client individually of what is most appropriate.
Can I intercede there? It's perhaps important to add that this is a service that's provided across the age span.
Yes.
So there are young people and children who are referred through to the service as well as adults.
We have restarted now to attend the Glasgow Paediatric Clinic, which has been really great because it is easier to do that work when you're present after COVID, and that will continue moving forward. So generally, it's really trying to be as accessible as we can be to as many people as we can be accessible to.
Then turning to the Scottish Infected Blood Psychology Service, would one of you like to tell us a little bit about when that started and a little bit about that scheme?
Yes, so I'll start off in the same way again. So that service started in September 2021, and they began seeing patients just a month later. It was funded again as a pilot over a 2-year period by the Scottish Government with the Scottish Infected Blood Support Scheme within the Scottish Government. We are currently in negotiation about the extension of that. The remit of that group, of that provision, is around both those who've been infected by contaminated blood and blood products. And a lot of their work has been about trying to establish that service with a number of individuals and promoting the service and access to that service.
And so you say that those that are infected can access services under the scheme. How about family members and carers and so on? Are they able to access support under the scheme?
Yes, yes, that's very much the case. We've tried to promote as open a policy as possible in order to engage people who may not be engaged in inherited blood diseases.
And again, similar questions about referral. Is the position in terms of referral that they can refer themselves or come through a variety of other avenues, including clinicians, charities, and so on?
That's right.
That service is delivered, I think you've already mentioned, delivered by a clinical psychologist, Dr. Gillanders. Is that right?
Correct.
Sorry, the transcript won't pick up your nodding, so if you can say yes or no.
Correct.
Thank you. In terms of again, in terms of what's on offer and how Dr. Gillanders works with patients under the scheme, is it a very similar picture to that you've outlined, Dr. O'Brien, for the inherited bleeding disorder service?
Yes, very, very much so. I think the service worked very hard. It's a little bit more challenging, I think, for the Scottish Infected Blood Psychology Service because they are trying to reach people who are across Scotland or possibly across the world who have received contaminated blood in many, many different ways. So it's a little bit more challenging to reach out to that group. It isn't maybe as straightforward for myself where I have 5 centres that I can base myself with. So they've worked incredibly hard at advertising their service through as many third sector charities as they can, linking in with the managed clinical networks that exist in Scotland to ensure they're aware of the service. They've created a website. They have advertised through the SIBS newsletters. They have made sure their information is available as many places as it can be. And then when that referral comes in, it is often through self-referral, given that often these people do not necessarily have a named clinician that would refer them. So the majority of their referrals would be self-referral. And again, it's trying to be as easy as possible for people.
And the reason why the service is working with people outside Scotland, because the criteria is whether or not the infected person or the has been infected in Scotland. Is that the criteria?
Absolutely. Anybody who is registered with SIBS can access the service.
And again, is there any limit on the number of sessions that can be provided, or is it, as you described for the inherited bleeding disorders, it's what's required?
Absolutely. Dr. Galanders would work in the same manner that we would work. Dr. Hacking, your witness statement tells us that the service has received 25 referrals, one from a clinician and 24 self-referrals. Do those figures remain broadly accurate?
No, there's been an increase from the statement that was provided, and there have been 28 referrals.
Thank you. Just before we leave you in Scotland, can you tell us about the cognitive screening tool that you've developed? What it is and when it's used?
So that is my colleague, Dr. Galanders, is also a neuropsychologist, so she has a great interest in cognitive, what is happening cognitively for.
Now, I think we've lost the transmission, I'm afraid, for a moment. So let's see if we can get that back. I think, were you going to move on, Ms. Scott? Do you have many more questions?
This was my last question specifically for Scotland, and I was going to ask some more general questions of the three nations' experience of these services.
Well, I think we'll have to come back to that. So, are we in a position to proceed now with England, with Dr. Stewart, or
yes, I could turn to Dr. Stewart now, and I could come back and ask those questions after.
The only problem with that is that the Scots, if I can call them that, may not hear, because if we've lost the transmission from them, they may have lost it from us.
Yes.
So I think what we better do is take a break. Let's say, so we say 10 minutes, and you'll be told if it needs to be longer. So I'm very sorry, but are you back?
Yes, we've just rejoined.
Right. Well, you've saved us the problem. We were just wondering what to do. We'd worked it out, and now you've come back, which solves it. Can I tell you where you were? You were going. Well, what was the last question? I've lost it off my screen.
I was asking them to tell us about the cognitive screening tool that they've developed.
And you better start again from scratch.
Okay. It was Dr. Galanders, my colleague that you mentioned previously, who developed the screening tool. From the evidence base, there is a suggestion that hepatitis C, HIV may have an impact on people's cognitive abilities. Sarah is a neuropsychologist, so it's an area she's particularly interested in, and was something that she developed to ensure that everybody was getting a helpful screening if it was necessary. So she has developed a short screening tool that she has shared with the other psychologists working in the area to allow people to do a screening, and if something is showing up, then if they have the skill, like neuropsychologists, they can move forward and do those assessments, or if it's appropriate to refer on to other services.
And when you say other psychologists working in the area, you're there referring to the psychologists working in the other specialist support schemes in Northern Ireland and Wales?
Absolutely. My understanding is they have a group where they meet and share learnings and things like that, and this is one of the topics that they've covered.
Thank you. I now want to ask some questions about the Infected Blood Psychology Network, and I'm going to turn to Dr. Coffey, because my understanding is, and correct me if I'm wrong, that it was Wales that started that network. Is that right?
Yeah, it was us.
And can you tell us what it is, who attends those meetings and what the purpose of those meetings are?
The purpose of the meetings was to, I guess, well, professionally network and bring, I suppose, services together to talk about how services were being delivered. So that's from the 4 nations, I guess. England haven't been as active a part in that network because obviously I think their services run slightly different. So the main aim from our perspective was to be able to make those professional links, but also to try and share some ideas about how we were running services, what was helpful, I guess, to learn from each other, but also to think about if there was ways that we could, I guess, combine some ways of working, because obviously, as we've said, there are people who might have received products while they were living in Wales, but now live in England. So, people don't stay in the same place. So we were trying to work out if there was a way of kind of, I guess, cross-working to increase access for people, I suppose, but also to increase the likelihood of somebody being able to be seen in person rather than virtually if they wanted. But mainly it was about professional links, but also about, just improving service provision, really.
And have you got anywhere with cross-working? Has that developed? Does that work?
I think we've definitely had conversations about how that would be received by the different services, and I know that everyone has been in favour of that. So if there was somebody who did want to be seen in person and they live in Wales, then I guess the service managers were in full agreement that we could try and work that out between us about how that would be, because the numbers wouldn't be huge. So I think, there definitely is an agreement and support for that. Yeah.
Is there any or has there been any discussion about parity in access to specialist psychological services?
Yeah, there's been quite a lot of discussion about that, I did say, because it does, it does look different depending on where you are, and it has been, I suppose, a topic between us professionally, and we have had some meetings with representatives and service managers from the English service to talk about our model, not just the Wales model, but the other nations' models in terms of how their service would develop. So yes, there have been discussions about whether there's shared provision,
And is parity in access to specialist psychological services something that you consider is important?
I think so, yeah.
Why?
I think it's because I think working clinically in this field, I think it's fair to say that the people that I've seen, and I know that the other nations would probably agree, I think from our discussions, that some of the difficulties that people present with are quite specialist and quite long term, and some of the feelings are quite entrenched, understandably, and I think it does need a specialist level of intervention. I'm not saying that can't be provided in other service provisions, but for me, I think it does feel important that there is definitely parity in how people access that and the quality of service that they receive. Yeah.
Can I turn to to Northern Ireland? Is there anything you want to add about the Infected Blood Psychology Network, or that issue of parity of access to specialist psychological services?
I think that's a big question across, irrespective of what area you're covering. Parity of access to psychological services probably is a wider discussion. I certainly feel yes, parity should be is important, and we should aim for it where at all possible. We don't have parity of access to psychological services generally across everywhere. So the English scheme of the IAP scheme, for example, is a mental health scheme which doesn't have replication in Northern Ireland, for example. But I think, yes, I think the other issue in terms of parity is people already are struggling with having felt, I suppose we often hear people talk about feeling like lower class citizens in terms of how they feel that they were treated, and any lack of parity contributes to those feelings and to that experience. And so that has a sort of ongoing psychological impact as well, in terms of feeling again that you're not, I suppose, receiving the support that perhaps someone in a similar situation would be. So I think in terms of specifically to this type of inquiry and challenge, then the parity issue becomes, I suppose, an additional stressor and challenge in terms of how people feel they're being supported on the back of the issues that have arisen.
Is Dr. Hacking or Dr. O'Brien, is there anything you want to add on those two issues?
I would like to add that I think it is important that the provision is specialist in the context of working within the medical services, and so that the clinicians who work in the services have an understanding and credibility about understanding the background that people have experienced. They are understanding the systems of care in which these individuals are being treated, and it enables those who are getting care through the service provision not to have to keep on repeating their story, which in effect can become re-traumatizing, to have to explain to multiple professionals all that they have been through and all that their family have been through, so that retaining the specialization of the services, to me, is very important in terms of the quality of care that's provided. I don't know if my colleague wants to add anything to that.
No, I would very much agree that often general services can underestimate or not quite understand the impact, and many people I've met have spoken about the frustrations of having to spend a session, 2 sessions, getting someone up to date, particularly if they've capped sessions in certain areas. So I do think it is a really important issue to be considered, and parity of access is so important. When we've heard through the whole inquiry people tell their stories and hear how distressing this has been, and I think it's really important that's acknowledged and legitimised through recommendations around parity of care.
And
Fully support that, and I suppose just the importance of it being within an MDT team. We've heard a little bit already about stigma associated particularly with seeking psychological services or therapies. I think the fact that the psychological care is considered as a holistic part of looking at care in terms of inherited blood diseases, then that actually is helpful in itself in terms of reducing stigma, that we are considering the needs of the whole person, including their psychological needs, and the importance of embedding it in MDT teams, and having that specialist knowledge helps to destigmatise the need to make sure that we're looking after psychological health as well as physical health.
So in terms of the specialist knowledge or the specialist understanding that the clinicians need to deliver the services, you've mentioned understanding the historical context, the stigma. Would it also include the history in terms of the sense of injustice that many have felt? And you've mentioned the consequences to some of not being able to seek access or not being able to access NHS care and treatment. And would it also include the fact that many have spent decades campaigning, so that wider context of how people have been infected and what's happened since they've been infected and the journey that they've been on? Are those the sorts of matters that you are suggesting a clinician delivering psychological services to someone that's been infected or affected should have an understanding of?
I think I can say that there's been nodding
Yes.
from both
Yes.
Dr. Hacking and from Dr. Meakin in particular for every point you've made in that list of points.
Yeah.
Dr. Coffey, is there something you wanted to add at this point?
I just would like to, agree with what you've just commented on. I think that the feedback that we've received in our service is similar to, I guess, what someone shared about, I suppose, not having to kind of, retell the story repeatedly, just having a not just a general understanding, but a clinical understanding. I guess it's not just about the kind of history, which maybe other people would know anyway, but it's about the clinical implication of that. I think is fundamentally important. Yeah.
And how did you, I say that collectively to all of those that are delivering the service, how did you gain that understanding yourselves before working with this client group?
Well, mine was through my clinical work in a HIV service and a hepatitis C service. So it was, I guess, clinically from being in that service for 10 years.
Does anyone else want to add anything to that question?
That would also be the experience in Northern Ireland, where our psychologist initially was providing services to our HIV population.
And our services are embedded within our wider clinical health psychology department. So as a specialist clinical health service, those, I suppose, those skill sets and that understanding is a big part of the delivery of care. And so there's also that sort of supervision and support. And just in terms of, for example, the cognitive screening tool, we also then have neuropsychology services as part of that holistic department, which means then we do have access to colleague support and being able to kind of cross-refer and pick up across the service. So I think that's very valuable as well, where it has that connectivity into the wider clinical health psychology services, as well as having that affiliation with specialist inherited blood services as well.
Yeah, I would agree from my service that a lot of learning is done working within physical health in general, in how to work within a medical system and what the barriers are to accessing care within a medical system, and then coming into post or prior to coming into post, really liaising with some of the third sector charities that exist was incredibly helpful at getting a little bit of knowledge. And the benefit of being a specialist service is you are meeting people and hearing their story, which is part of the job. But over time, you really get to have a feel for what the journey was like for certain areas or in certain situations. How, and as you alluded to, how did the infection happen? How is this information shared? What was the journey after that? So there's so many little points in the journey that could be very traumatizing for people. And I think being a specialist service, you pick up that knowledge very quickly rather than possibly seeing one person in your career that's had this experience.
You all described a service that's able to be flexible to the needs of the patients that are coming for support. This inquiry has heard evidence from some who have gone for support and been given a defined amount of therapy sessions. Is there anything that you can tell us about the advantages to the more flexible service for this particular group of patients versus a perhaps saying, well, you've got 10 sessions or you've got 12 sessions approach?
I just think the issues are ongoing. I think, the inquiry is happening. People's health, is poor. It's not something that's kind of finished and completed. it's something that's reactivated at different points in their life, possibly when they enter a new relationship, or when their health changes, or when their medication changes, or when something, you know, deteriorates. Or I think it's not something that you can necessarily kind of package up into 10 appointments. It's not a here and that now issue like some psychological difficulties might be. It's something, yeah, that's, as I said, long term, and some of these feelings are understandably very entrenched. So I think having that flexible approach is, yeah, it's so valuable, because, you know, people aren't, it's not something that can be, yeah, neat and tidily kind of resolved, I don't think.
And is there an advantage or perhaps a disadvantage in the fact that people can dip in and out of the service and come back and they will likely see the same person?
I think that's always the preferred option within a psychology framework, because obviously you build up that therapeutic relationship and that rapport with someone. So that would be, yeah, that would be the preferred option in most places. But I think, again, with this particular work, because of that injustice or that done to that's happened for people, I think having that same clinician where you can have periods of therapy and then have breaks if that's what's considered appropriate, I think is really important. And it's certainly the feedback we've had in the service, because I've seen people for sections of time, and we've taken breaks and we've paused and come back, and then I've seen them with family members, or I think it's sometimes pieces of work, yeah.
I've seen nodding from Dr. Meakin. Is there anything you'd like to add to that, Dr. Meakin?
I think that's really crucial, actually, within working with long-term conditions. You know, so there is the overlay of the kind of challenges of the infected blood, but it also is a challenge of living with a long-term condition, which in itself has a pathway and differing challenges along that pathway. I think it's also really important because when you're in the midst of an inquiry like this, there will be times whenever your resources will need to be focused on something in particular, and that may not be kind of the psychological therapy at that point in time. You may need to focus on, you know, giving evidence, or, you know, and so you may need to kind of contain and manage, and actually the importance of being able to have some flexibility in when you have the resources to manage the emotional component and to have the space to do some psychological therapy, but also the time to know that actually I need to take a step and I will come back, and the availability of that is really crucial for people feeling, I suppose, held in the midst of what is something which is very complex and challenging and has so much to manage at the minute. So I think that is really important. And you may well do blocks of sessions of therapy, but I think it's important that it isn't felt that that's done and dusted and dealt with. There will be other things that come up, and other losses that you have to deal with, and other adjustments that you have to make, and that's part of the journey of a chronic physical health condition, never mind the journey of having to deal with an inquiry and the issues that go with that.
Dr. O'Brien, is there anything you would wish to add to that?
I think I was nodding a lot because I think I agree with a lot of what was said, and definitely the feedback we've had in Scotland has been that appreciation to be able to reach out when that support is needed for whatever reason, but also to know that that support will continue to be there. And I think that's been a really important change for some people in a healthcare professional relationship, that it's been a very stabilizing relationship for people, and sometimes we may do, you know, 3 sessions and not see someone for a while, and then they will come back for another phase of work, and it is a very successful model in Scotland.
This touches on the point that we were discussing earlier, that the length of time that these services are likely to be required by this community. Does anyone have a view about that?
I think they will be required for a very long time.
Yeah.
in terms of kind of moving out of an inquiry phase and then having to make sense of all that has been said and dealt with, and actually maybe having that space to have a more of a breath, to take emotional and psychological account, but also that as physical health changes and differences occur in terms of your mobility, ability, whether further losses are suffered, then that journey continues. And I suppose there are journeys of people who in some ways are just starting, and that affected over, people who have had losses but go through new aspects of their lives in terms of the affected and have to deal with someone not being present for other aspects of their life, then there may be a need to dip in and revisit the impact that that's had. And I'm thinking of things like getting married or having children, and suddenly people not being there for you, then those are the kind of times when you might need to back in and dip back in for some support around that as new emotions or old emotions resurface again.
Does anyone else want to add anything?
Well, Scotland,
Yes, sorry.
yes, I'd like to say that in Scotland there has been a commitment by NHS Lothian to establish the psychological support service within the eating disorders service, because there is a recognition that ongoing psychological treatment and psychological interventions will be required for this population of people. So there has been that decision that has been made, so that we will be taking over the funding of the posts from the initial funding from the Scottish Government and NHS Service Division.
I suppose in Northern Ireland, just in Caroline's, that our trust has a commitment to do that as well, in terms of acknowledging the needs of the width of the inherited blood disorders, of which the infected and affected will continue to form a part, and to continue to support that service moving forward.
That's correct, because it strikes me that between Scotland and ourselves in Northern Ireland, we started from slightly different positions. We focused immediately on the infected and affected and want to extend beyond that, because we see the therapeutic value of ongoing psychological support associated with inherited bleeding disorders, whereas you started with the premise that we now see that you need psychological support long-term associated with inherited bleeding disorders, of which the infected and affected were a subset. But I think the end point is the same, namely that there is a requirement for a consistent and long-term specialist psychological support to this group of people, in ensuring that there's a holistic approach to their care.
Dr. Coffey, is there anything you want to add?
I guess only in that I can't see a time when it wouldn't be needed. Even, I guess, in the clinical work that we're doing in the service now, I suppose we are thinking with people about what, how to do the preparatory work for the inquiry ending, because obviously having an ending to something is always going to have an emotional and a psychological reaction in terms of justice or injustice, or however we frame it. So we've definitely begun that work with the people that we're seeing. But in terms of what I've said, I can't imagine the specialist service that we provide not being needed. I don't know what would need to happen in order for it to not be needed, because the issues are ongoing. Yeah.
And just before I turn to Dr. Stewart, who, to ask what the position is in England, is there anything that any of you would like to tell us about what you think works particularly well, or perhaps doesn't work so well and could be improved in the specialist services?
And I'll be start. I mean, I think it's great to have the dedicated time and the reasonable amount of it specifically in. And I think the flexibility to offer individualised support, depending on kind of what the need is of that person at that time. I think for us, that the need to widen that in so that it becomes more established as part of the offer of the MDT team is the important bit as well, in terms of it not being seen as, I suppose, that kind of slight sort of still stigma of kind of almost having to go for psychology because you're not coping, whereas it really should be about maintaining psychological well-being in the face of very extreme challenge and difficult circumstances. So I think for us, you know, the ability that we are now looking at to move towards that will, in my view, significantly improve the service delivery and hopefully, you know, then embed it much more and so that we will be able to offer and meet the needs of the wider population and make it much more just a part of their care moving forward.
Anything else from anyone else?
I think something that's, I suppose, been a noticeable, I suppose, helpful, I suppose, way that we've managed to run the service is just having that time and, I suppose, space with people to build that relationship and that rapport. Because obviously I think we were quite, I think we wanted to be quite open and honest about conversations about us, you know, as the service being part of an organisation where these difficulties were created. So I think just having that respect and time with people to talk about how we kind of break down some of those barriers of mistrust, understandably, has been really important for us as a service. And I think people have really appreciated that style of work.
I'm going to...
I've only got one...
Go, sorry, yes.
I've only got one small thing to say there, which is around when you think about the experience of the individuals who've been infected or affected by contaminated blood, trust is a key issue. A lot of individuals, that sense of trust in their healthcare organisation has been undermined by their experience of having been affected by contaminated blood. So there is something important about the continuity of service provision for this group, and recognising too, as I think has been pointed out, the experience of going through public inquiry for many will have been very difficult. Yeah. So it seems particularly important that the services are maintained and that there's a commitment for that.
Yeah. I'm going to turn now to Dr. Stewart. So we've heard mention of IAPT, or improving access to psychological therapies. So can you tell us about that and how people can access that?
Yes, of course. And the context in England, because of the improving access to psychological therapies, or we quite often refer to it as IAPT, and the existence of IAPT. So IAPT is a service that exists in every locality in England. They're very accessible. People can self-refer, or they can get a referral through their GP. You can just go up onto the NHS website, and there is a search facility to find your local service. It's a service that was introduced about 15 years ago, and is in the process of being expanded, and has been expanded over the years, and will continue to expand over the coming years. It is a service that is available to treat a lot of common mental health problems, so depression, anxiety disorders, and post-traumatic stress reactions, and is based on evidence-based effective psychological therapy services that are recommended by NICE, which is the National Institute for Health and Clinical Excellence. It has a number of standards associated with the service, one of which is waiting time standards. There are 2 waiting time standards. The first is that 75% of people can access the service within 6 weeks of referral or self-referral. The second is that 95% of people are seen within 18 weeks I'm pleased to say that we're currently exceeding those targets. So data from August was published yesterday, and we are seeing 88.6% of people within 6 weeks, and 98.4% are seen within 18 weeks. In fact, in every single integrated care system, so an integrated care system is the local unit for the NHS in England. There are 42 of them across England. There is an integrated long-term conditions pathway with an additional senior psychological therapists within that, so that they have knowledge of and can support people in long-term conditions pathways. We did a survey in September of this year, and assured ourselves that that existed in every single integrated care system. There are also targets in relation to recovery of people accessing the service. And so that is the current context in England. We will, as I said, we have a big programme of expansion and transformation of mental health services underway in England at present, and one of the components of that is to continue expansion of the Improving Access to Psychological Therapies programme.
And so what is the criteria for accessing help? If you were to self-refer into IAPT and then you'd be directed to your local provision,
Yes.
would the criteria depend on what the local integrated care system's criteria was?
It would be whether you were whether your condition met thresholds for and the services that provided. So, for example, if you presented with an eating disorder, you would not be eligible for IAPT, because the service does not treat eating disorders, for example.
So, and are those thresholds, are those national thresholds, or are they local thresholds?
I think those are set out. We have quite a comprehensive manual set out for improving access to psychological therapies, to IAPT, which sets out kind of expectations of individual services across the country.
So somebody presenting with depression and anxiety, for example, could go onto IAPT, be directed through to their local integrated care system, and they can expect to be, the threshold can expect to be the same as somebody who's in the other end of the country presenting in a similar way.
That is my expectation, yes. And I should probably just clarify, you mentioned most integrated care services would have more than one IAPT service within them. So they exist universally, but cover a smaller geography usually than an integrated care system. I think these are now not the most recent statistics, but can we just look at the data from July to try and understand what that means? It's RLIT 301860. So here we've got a document from NHS Digital Psychological Therapies, reports on the use of IAPT services, July 2022. And we can see it's published on the 13th of October 2022. And it's just the key facts I want to go through with you on page 3. So I think you said that there are some more up-to-date ones than this, but if we just look at the July ones, in July 2022, there were 131,766 referrals to talking therapy. So that figure is self-referral or referral through GP, etc. Yes, that's right.
And then if we come back to the second bullet point in a minute and just go down to the 96,156 referrals accessing IAPT. So what do we understand? What's happened to the difference between those two numbers?
The they will have a lot of them will have a condition that isn't suitable or amenable for IAPT.
So for whatever reason, those people would not have been accepted onto the service.
Yeah.
And then if we go back to 2, it's the second bullet point down, we can see at that point it was 88.7% of referrals accessing IAPT within 6 weeks. And I think you said that has come down slightly in the August to 88.6.
So 88.6, yes, only marginally.
And so that means, does it, that within 6 weeks somebody will have seen a therapist of some sort?
Yes.
And then if we go down to the fourth down, we see 8.1 sessions of treatment on average per referral. So are you able to help us with whether or not the different services under IAPT limit numbers of sessions, or whether they're open-ended, or does it just depend on what the service is?
I would need to check with kind of experts on the service. I know actually that figure has changed over time. I think in particular what we're seeing is increased acuity as a result of the COVID pandemic. So on average, we are seeing people are receiving more sessions of treatment than they were prior to the pandemic. So that has increased, reflecting the need.
And do you know whether under IAPT the kinds of services that have been described by earlier this afternoon, so people being able to dip in and out of services and come back to the same therapist, people being able to be given family therapy or different kinds of therapy, people being able to have short pieces of work or long pieces of work done with them, is that something that's open and available under IAPT, or does it depend?
So it depends on the different circumstances in that list. So IAPT, so if you're, it is quite often described as a mild to moderate service. It can actually deal with quite severe cases as well, but only within those conditions that it is specifically set up to treat. So back to the anxiety, depression, post-traumatic stress reactions. It would not be able to provide the more complex or some of the multidisciplinary treatment that has been described by colleagues as being on offer under the specialist services. However, I would reiterate what I said slightly earlier in that there are also long-term conditions specialists and pathways available within IAPT.
And I'll come back to ask you some of that. Yeah. You can take that down, Lawrence, about that specifically. And is this right? Is it also right that presumably you wouldn't be able to get a therapist who understood the historical context of infected blood in the way that's been described earlier this afternoon if you went down the IAPT route?
So you might have someone who had expertise in long-term conditions. It wouldn't necessarily be infected blood, but the Department of Health and Social Care has work underway that it might be worth telling you about, which is to develop a specific resource for practitioners that would give them the advice, the expertise in terms of infected blood, precisely to address some of the scenarios that colleagues were describing earlier.
And I'm going to ask you about that in a little bit later on. So just then returning to the other ways in which individuals can access support in England, you've mentioned already that there are specialist, in the specialist services, so for hepatitis C and the HIV clinics, is that right, that there is access through those routes to psychological support?
As part of those services, yes, as distinct from the specific mental health services.
And then also your statement makes it clear that EBS also provides money for private therapy, £900 per annum to pay for private therapy.
Yes, that is correct, and I think that is a development since I think the Department of Health last gave evidence to this inquiry. There is now, for anyone for whom IAPT isn't appropriate, or they choose not to go the IAPT route, whether they're infected or affected, they can apply to EABS for a grant.
So I see the time. We've been going for about an hour and a half. I probably have about 10 to 15 minutes left, or 10 minutes left of questioning, I would have thought, maybe 15.
So what are you suggesting? What are you asking me to do?
I don't know. It depends, I suspect, on the witnesses and on the shorthand writers as to what we do, but I'm in your hands.
Yes. The choice is between having a break now, coming back, having a further 15 or so minutes, then having another break, because Council will need to be able to field questions from core participants. They have a right to put questions through to you, through their legal representatives. Plainly, there may be a number of issues or questions which arise out of the evidence you're all giving. So the chances are, the best way of putting it is this: we can go on for 15 minutes or thereabouts now, take a break, it'll be one break, and then come back and finish off. Or we're going to have two breaks. The first, sensibly, to allow people to have a cup of tea, etc., will have to be 20 minutes or so, and then a further break of 20 minutes, half an hour later on. So its choice is yours. You may think it would take rather less time to go ahead now, providing the stenographers are not exhausted.
I'm told that they are content to go on.
They're content to stay on?
Yes.
But if any of you want a break, please tell me and we'll have one.
I'm happy to go on.
Yeah,
Right, let's go.
I just want to explore with you, Dr. Stewart, the decision-making process thus far in England about a specialist psychological service for infected and affected, the infected and affected. From the evidence you gave earlier, right to understand the Department of Health and Social Care is the decision maker as to whether or not to commission and to fund that service.
That is correct. So the Department of Health and Social Care and its ministers would be responsible for making the decision about whether or not any additional or different services needed to be commissioned.
And has NHS England, in its advisory capacity, given any advice to the Department of Health and Social Care about that issue?
So we have, so starting back in 2020, we gave advice to the Department of Health and ministers on potential options for support, ranging from the do nothing to providing specialist support.
And that was advice sketching out, was it the options? Was it saying what NHS England thought should happen?
I don't believe it was, but I have that advice in front of me, so I am just going to double check. So as not to mislead you. No, I don't think we did. We gave them options that included improving access to existing NHS services through EABS, expansion of pre-existing services and bespoke psychological support services, and set out what then taking that forward would involve. We didn't recommend a specific option in that advice we put in writing.
I think there may be actually some help given to you, because I'm looking at a witness statement which was given to the inquiry by William Vinell, the civil servant, of the 23rd of April 2021. And in paragraph 70 of that...
Should we just get that up on the screen? It's WITN 4688055.
Thank you. And at internal page 20, paragraph 70, you may want to consider this. The Parliamentary Secretary for Patient Safety, Suicide Prevention and Mental Health, at the time that was Nadine Dorris, had a meeting with Claire Murdoch and then requested NHSE/I to investigate options for the provision of psychological support, and that, I think, is what you've been asked about.
Yes.
Reported back to the department. Using this information, departmental officials prepared advice for the Parliamentary Secretary on mental health support for the infected and affected. The preferred option, accepted by PSPSM, involved creating a bespoke, using that word, psychological support service for people under EBS jurisdiction. So in its terms, it looks as though that's looking at a service which is rather similar to the service operating in Scotland and Wales and Northern Ireland at the moment. And then it goes on to say what some of the suggestions were coming from NHSE, amongst which I noticed C, a specific psychological therapy service for some service users, which may relate to the bespoke idea, but I think the summary is there as to what the outcome was, and that reflects presumably the advice received.
Yes, so the wording there is the third option that is in William Vinall's statement is the summary that is in the paper I've got in front of me as well, in terms of a third option that was presented to ministers.
And that's what it seems that the minister at the time thought would be the proper route to go down.
Yes, that's right. That's correct.
And do you know, can you help us as to why, given that that seemed to be the position in February 2020, that we're seemingly or there doesn't seem to be made a decision doesn't seem to be made to commission such a service?
So I think the timing of that advice and when it would be taken forward is also very relevant. It was shortly before the COVID pandemic hit, and then both NHS England and Department of Health and Social Care officials were diverted to deal with the pandemic, and that will have taken up significant time and effort. There were then further conversations between ourselves, DHSC and EBS at points over the years, and I'm aware that I think when William Vinall and the Secretary of State came back to give evidence, I think they came and gave evidence in person at a later date. At that point, the position had evolved, and I think William Vinall described it as that point as having made a decision that EBS or the conversations at that point were looking at EBS commissioning a specialist assessment that would signpost to IAPT, whilst also further consideration was given to specialist support. There have been a number of meetings over the course of the last year, looking between the different bodies, looking at and considering how to evolve and where to go next, and ultimately where we have landed at present, though there will be further evidence and advice gathered and put to ministers for further decisions. So where we are at present is that the Infected Blood Service have made further enhancements, or have made enhancements to their website with input from our clinical experts. And the website now sets out information on existing NHS talking therapies, so IAPT, and how to access them. It also has information on how to access the grant of £900 for access to psychological support that is available. There is further work underway as well that I'm aware of that I'm happy to tell you about if you would find that helpful.
Yes, so you mentioned that in your witness statement. You can take that down, right? Thanks. A plan, and you've already mentioned this in your evidence, a plan by the Department of Health and Social Care to develop a practitioner-facing resource. That is. Do you know how advanced those plans are? Is that going forward?
That would be a question you'd have to ask the Department of Health and Social Care. I don't know precisely where they are on that at the moment.
So you don't know who is involved in that work, or the timescales, or what it would involve?
I don't know where they are in terms of current timescales. No.
And do you know who is involved in that piece of work other than the Department of Health and Social Care?
I know they have found experts to advise them on its content. I don't know who those experts are. Colleagues of mine may well know. It's not necessarily but I personally do not know who those experts are.
And so I should just say we have asked the Department of Health and Social Care about that, and they are going to respond to us. They are going to respond to us, but haven't done so yet. But the time for them to respond came after this hearing. And you've also mentioned in your statement the commissioning of additional research by the Department of Health and Social Care to understand in greater detail the psychological treatment needs of those infected and affected, so that a comprehensive gap analysis can be completed. Do you know what's happening in relation to that?
That would be a question for the Department of Health and Social Care to answer.
So you don't know whether that's already been commissioned?
I think it has been commissioned, but I don't know the timescales for it to report.
And again, do you know who is doing that research?
I don't know who's doing that research. That would be a question for the Department of Health and Social Care.
So we can presume from that it's not NHS England, is that?
It is not NHS England doing that, no.
And then you've also said you understand that DHSC has asked NHS BSA to publish additional enhancement to the EABS offer on their website in the next few months. Do you know what those enhancements are?
Again, I'm afraid you'd need to refer to the BSA or DHSC, I think, for those further details.
So those were the questions that I had for these witnesses.
Yes, well, very well. We'll take a break now. Do you have any sense of how many questions there may be?
I don't know.
So if we take a break for 25 minutes, let's say we come back at 25 to 5, no earlier than 25 to 5, I should say. That gives you time. The reason I say no earlier is it may be slightly longer. If so, you'll be told. And I can't tell you how long it'll be after that, because it depends how many questions there are. But that's what we'll do. So 25 to 5.